Hello, this is Dr. Pankaj Jindal. I'm a hand surgeon in the city of Pune in the state of Maharashtra in India. We'll talk about a presentation of a doctor who had multiple fractures in a small finger. So if you appreciate, this is the only X-ray that was available because of the severity of pain, and we have to discuss what all went wrong in this injury. So if you see a lateral of this distal phalanx, he had a mallet deformity, he had a bony mallet, he had a fracture of the base of the distal phalanx. Going the PA view, you see he has an intra-articular fracture of the middle phalanx. If you see more proximally, that is the proximal phalanx, he has a fracture of the shaft of the proximal phalanx of the small finger. In the same finger, he also had a fracture of the neck of the metacarpal 5. So with these 4 injuries, how do you go about managing these things? Well, we have a choice of fixing all the fractures individually, as again this is a different patient. A same wire can be passed across all the 3 phalanges, all the interphalangeal joints, all the metacarpal, and give rise to a single fixation. But the moment you use a single K-wire fixation, the possibility of stiffening this finger is extremely high, and the length of time that will be required for mobilizing after wire removal will be in months, and probably still a residual stiffness will be there in this finger. And therefore, our choice of fixing such a patient with fracture of the same ray with multiple fractures is individual fixation. So we put 2 K wires and treated this with a reduction of the distal phalanx. Similar 2 K wires were put into the head of the middle phalanx. A single K wire from the as lateral entry as possible, stabilizing the proximal phalanx, and bouquet technique or Fouché technique to reduce and immobilize and stabilize the fracture of the 5th metacarpal. So you will appreciate we have not violated any of the joints, not the MP joint, not the PIP joint, not the DIP joint, and the joints are free, and therefore patient is free to move his fingers early. Did it give results? Let's see in a little while. So in the magnification, you will appreciate 2 K wires in the distal phalanx, 2 in the head, in the proximal phalanx, and into the bouquet technique in the 5th metacarpal. The patient stayed far off, and he sent in this video, and he said he has full extension of the fingers, he has full flexion, he has some residual restriction of flexion. The important thing was, after the surgery, most of the follow-up was done by video conferencing, and this is the range of motion we got of this. He said, I am almost forgotten about this injury and has gone back to his original task of being a doctor. So you can get a good range of motion. The bottom line that you need to learn here is, do not fix it with a single K wire. Try to mobilize the joints as early as possible, and you can optimize the great range of motion in such an injury. I thank you once again for patient listening. Any feedback is most welcome. Thank you once again.